Hi everyone, this is Harshita. Welcome to Teddy Gets You channel. So today in this video we are going to discuss an important topic, that is sideroblastic anemia. In the last class we discussed everything about the iron deficiency anemia. So this sideroblastic anemia is completely opposite to the iron deficiency anemia, because iron deficiency anemia is causing as a result of decrease in iron. Iron is getting decreased, maybe because of socioeconomic status or because of any absorption problem or because of any anemia of chronic diseases. So all the iron in the body is getting decreased, whereas in sideroblastic anemia iron overload can be seen. And the question is, even though the iron is overloading here, why we are getting anemia? The iron is overload, but the overload is seen in the erythroid precursor cells. So the iron present in these EP cells is not eligible or is not used to form the RBC. Okay, so this is called as sideroblastic anemia. So now let's decode the name sideroblastic anemia. Sider means iron, blastic means immature cells. So iron is present in immature precursor cells, hence it is not useful to prepare the RBC. Okay. So now let's discuss the causes. So what are the causes? The causes may be of two types. First one is genetic and second one is acquired. So genetic may be because of enzyme deficiency or because of X-linked sideroblastic anemia, and acquired may be due to alcohol. Alcohol is mitochondrial poison. Okay, so the most important thing that you should remember is alcohol is mitochondrial poison. Next one is anti-tuberculosis drugs like isoniazid. And the next one is vitamin B6 deficiency. So these are the reasons to get sideroblastic anemia. First one is genetic, enzyme deficiency, X-linked sideroblastic anemia. Next one is acquired, maybe due to alcohol, anti-TB drugs and vitamin B6 deficiency. Okay, now let's go into the pathogenesis. In pathogenesis, we first discuss about the HB synthesis. You may be learned this about HB synthesis in your biochemistry first year classes. So the thing that we should considering it first, succinyl coenzyme A. This succinyl coenzyme A is converted into ALA. ALA is produced here with the enzyme called as ALA synthase. Okay, and now this ALA is furtherly converted into porphobilinogen production, and this porphobilinogen is converted into protoporphyrin. Okay, with this iron will join to produce heme. So the enzymes are, first one is ALA synthase, and ALA is converted into porphobilinogen with the help of ALA dehydratase. And from porphobilinogen it is converted into protoporphyrin. Many reactions. These here we undergo many reactions which gives rise to the protoporphyrin. Okay. Now these protoporphyrin occurs in the mitochondrial. So this is very important to discuss, and they both combine in the presence of iron chelatase to give heme. If there is any deficiency of ALA synthase or ALA dehydratase or any kind of enzymes here, it will lead to the sideroblastic anemia. Next one is rate limiting step. Here ALA synthesis is the rate limiting step. So this is the thing that you should remember in your pathogenesis. Next one is, here we are having iron. Here you are having iron, but the problem is protoporphyrin is deficient here. Why? Maybe because of these enzymes, or maybe because of this mitochondrial poison, that is alcohol. So because of these conditions, protoporphyrin will decreases. Iron is there, but his friend protoporphyrin is absent, because of which we are unable to see the production of heme. So that is the point here. And vitamin B6 is also needed for the production of hemoglobin synthesis. Now let's discuss some important point about the bone marrow aspiration. For example, let me draw a mitochondria for you. This is mitochondria. That is the nucleus, and in the perinuclear location there will be presence of mitochondria, and in this mitochondria you can observe the accumulation of iron. So iron is presented in the perinuclear sites. If it is greater than 5 iron granules, then it is called as ringed sideroblast. So iron is present as granules in the perinuclear area. So these are the structures you can see in the bone marrow aspiration. As there is iron accumulation, they can be strained with the Persian blue strain. Okay. CBC hemoglobin decreases. TLC platelets will be normal, and RBC indexes like MCV, MCH, MCHC all will get decreased. Okay. Next one is peripheral smear. In peripheral smear, you can observe Pappenheimer's bodies. Pappenheimer's. These are nothing but the accumulation of iron in the mature RBC. Next, you can observe the microcytic hypochromic red cells and coarse basophilic stipping. So these are the peripheral smear findings you can observe in the sideroblastic anemia. Next one is iron profile. Here everything will be opposite to the iron deficiency anemia. For example, serum iron will be increased because iron is normal. Actually, it is overloading. So serum iron will be increased, and serum ferritin will also be increased, and serum total iron binding capacity will be decreased. Capacity is getting decreased, but serum iron will be normal, and TS will be increased. So what is the treatment that you are going to give to your patient? It is phlebotomy or any iron chelators. Phlebotomy means you will advise him for blood transfusions for 2 months, or you will give iron chelators to break the iron. So this is the treatment that you should give to a patient who is coming to you with sideroblastic anemia. So these are the points that you must remember about the sideroblastic anemia. So I hope you understand the class. If you not yet subscribed to the channel, please consider subscribing to the channel to educate you. This is K Harshita signing off. Thank you so much.